Hi learners, welcome to another mini lesson. This one is going to focus on burns, wounds, and tissue repair. The tissue repair is very basic, so you'll get a lot more of that in anatomy and physiology. This really just introduces you to some terminology. So let's start on burns. Burns are the leading cause of accidental death. The immediate cause for concern with major burns is fluid loss, infection, and systemic effects of the burned dead tissue. So we classify burns according to the depth of the tissue involved. The terminology here has been changing over the last few years. We used to do degrees, so first degree, second degree, third degree. Now we talk about the depth, so superficial, partial thickness, and full thickness. So first degree burns, we really refer to them now as superficial burns. So what you're seeing in this picture is a first degree burn or a superficial burn. This type of burn involves only the outermost layer of skin, so only the epidermis is involved. It produces inflammation, redness, pain, and maybe some slight swelling or edema. Remember, edema means swelling. These burns heal pretty quickly, usually only in a few days, and they don't leave any scars. So something like prolonged exposure to the sun or a short exposure to a hot surface will cause a superficial burn. Second degree burns are called partial thickness burns, and they involve both the epidermis and the dermis. They cause inflammation, redness, and much more intense pain. The key difference between superficial burns and partial thickness burns is the presence of blisters in a partial thickness burn. So these types of burns usually heal in a few weeks and leave minimal scars. So something like boiling water or a scald will cause a second degree burn or a partial thickness burn. Third degree burns are referred to as full thickness burns. These are the most serious types of burns and involve all layers of the skin. The epidermis, the dermis, and subcutaneous tissues are destroyed. The burns appear charred, browned, or blackened. And believe it or not, they're not very painful because the nerve tissues have been destroyed. The areas around the burn, which are generally second degree burns, around the third degree burn, are very, very painful. And the problem here is that you've lost like in a second degree burn, you've lost the outer protective layer of skin, so the person is at huge risk for infection. And like a second degree burn, if they're very extensive, you've lost the ability to hold fluid in the body, so they're at risk for huge fluid losses. So fluid loss and infection are huge dangers with major burns. A fourth degree burn is also known as a full thickness burn, but the damage is more extensive and can involve muscle, tendon, and even bone. So these types of burns can be caused by prolonged exposure to fire or high voltage electrical injuries. These types of injuries require major medical intervention and can, like I said, can produce not only severe pain, but increased risk for infection and the need for major reconstructive surgery. We'll talk about that in a couple more slides. So the leathery dead tissue that you see on top of a burn is called eschar. The problem with eschar is it is inflexible and can cause problems with breathing if it's on the chest or the back, and can prevent wound healing, and it leads to infection. So it's like, imagine a leather belt over the skin. It doesn't stretch, it's completely inflexible, and it breeds infection. So the eschar must be removed, and the process of removing it is called an escharotomy. The otomy means incision. Your book also uses the term debridement. So debridement refers to the removal of dead or necrotic tissue. An escharotomy refers to the cutting and removing of eschar specifically. So you'll see in the pictures on the right that the escharotomy has been done to release the tension of the eschar. In a debridement, it can refer to cutting or removing any dead or necrotic tissue in any kind of wound. So superficial and partial thickness burns will heal themselves through regeneration of the skin or regrowing of the skin. In full thickness burns, there's no dermal tissue, no tissue in the dermis left to regenerate. So skin grafts are needed. Ideally, an autograft is the best solution. In an autograft, the skin is taken from another location on the same patient and transplanted to the burned area. So if you break down the term autograft, graft means transplant and auto means self. So you're transplanting the skin from yourself. If the patient has extensive burns, there's other options, like if there's just no available good skin on the person. Allograft and homograft mean the same thing. So in allograft or homograft, the grafts are taken from cadavers. So if you break down the term, remember graft means transplant, allo means other. In homograft, the prefix homo means same or alike. So homograft means you're taking a graft from the same species. So homograft and allograft mean the same thing. You're taking skin from a cadaver. Another type of skin graft is xenograft or heterograft. Those two terms mean the same thing. But in these terms, we're taking it from a different species. So xeno means foreign and hetero means different. So in a xenograft or a heterograft, we're usually taking skin from a different species. Usually it's a pig. Pig skin or porcine skin is very much like human skin, and they transplant very well. So xeno means foreign, hetero means different. Again, graft means transplant. So it works very well to replace the skin in burn patients. When we're treating burn patients, we need to know how much of the person's body has been affected by the burns. So in order to calculate it, we divide the body up into sections or regions, as seen here in the picture, and each section is assigned a fraction or a multiple of 9, and it gives us an approximate percentage of the body surface area affected by the burns. We call this the rule of 9s. So here, if you look at the picture, the head and the neck are 9%, 4.5 on the front and 4.5 on the back. Each arm is 9%, again, 4.5 anterior, 4.5 posterior. The legs are larger, so they're assigned 18%, 9 anterior, 9 posterior. The entire anterior trunk is 18, and the entire posterior trunk is 18. So you could divide the top and bottom into 9 and 9 if you want. And if you're keeping up with the math, that's a total of 99%, so the remaining 1% is for the genitalia. This rule of 9s, as seen here, is for adult patients, and in children, the numbers are modified a bit to account for their different body proportions. So we use this rule of 9s to estimate the severity of burns, and in some cases it helps determine treatment options, like if we need to transfer a patient to a burn center rather than a regular hospital, for example. So let's go back and look at this patient, or these two patients, I should say, for example. The one on the left, the website that I got this for, this was a left anterior arm. So assuming the patient had no other burns anywhere on the body, this patient here, if we assume that that's the only burn, what percentage would you say this person's burn was? A burn covering the entire, one side of the entire left anterior arm. So if we look back at our rule of 9s, the left anterior arm would account for 4.5%. So we would say this person had burns on 4.5% of their body. Okay, good. So we go back to this picture. This person has one arm covered with third-degree burns on the front and back of their, what is that, right arm? On their right arm, front and back. Assuming there's no burns anywhere else on their body, what percentage would you say using our rule of 9s? We go back to our picture. Front and back of one arm would be 9%, because one side is 4.5, the other side is 4.5. So 4.5 plus 4.5 is 9%. So that person would have 9.9% third-degree burns. So that's how we calculate using the rule of 9s. Okay? All right, so that was a very, very brief overview of burns. I could teach an entire class on nothing but burns. So that is a very, very brief overview of burns. So this is going to be a very, very brief overview of wounds, because you can get an entire certificate, a whole semester on nothing but wounds, and there are nurses that do nothing but wounds as their whole career. So this is, again, a very, very quick overview of wounds. So, wound and tissue repair. So a laceration is just simply a cut that damages primarily the epidermis and maybe a little bit of the dermis. Epithelial cells will divide rapidly and then fill in the gap to start the healing process. If the damage extends deep enough to damage blood vessels, then blood will escape into that gap and you'll see bleeding in the wound, obviously. An incision is basically a deep laceration that's made for surgical purposes, a nice clean surgical cut. The blood that has escaped into the wound will form a clot, and a clot consists of fibrin, platelets, which are also called thrombocytes, if you remember that from A&P, blood cells, and dry tissue fluids. The fibrin threads, remember fibrin's that protein and threads, it's a stringy protein. The fibrin threads create like a net that traps all those particles and creates the clot, and that will help stop bleeding. Macrophages, we'll go into all kinds of A&P here. Macrophages are those big white blood cells that will travel to the site, and macrophages are big eaters. Those big eater blood cells, remember macro means big, phage means to eat. So macrophages are those big eater white blood cells that will travel to the site to help clean up tissue debris. And eventually the surface of that clot will harden and form a scab, and that will help seal and protect the wound, the wound from an infection. So there's a whole lot more physiology here. What's my next slide? Yeah. There's a whole lot more physiology here, but that's the very, very basics. Fibroblasts will enter the site and they're going to start laying down collagen. Collagen is what's going to start to form scar tissue. Collagen is the connective tissue that's going to start to form a scar. The collagen is going to start pulling the wound together, and that new, soft, healing kind of tissue is granulation tissue. So that granular tissue, sometimes we call it granular tissue or granulation tissue, is what we want. That's that new tissue that's healing. And if you ever talk to a wound care nurse, they love granulation tissue because that's the good stuff. That's the good healing tissue. It looks pink and healthy, and it takes a while to completely heal, but that's what's under that scab. So if that was open, we'd see nice, pink, healthy tissue underneath. So as the healing continues, a couple of weeks go by, the scar will form from the collagen being laid down. These are excessive collagen fibers, so these are called keloids. This one really isn't that bad. This one is very excessive. They're considering this one a keloid. That doesn't look too bad to me, but this one is a little bit excessive. So if it's excessive, lumpy, irregular, they call it a keloid. So if the keloid is very bad, it can be surgically removed. The problem is somebody is what they call a keloid former. If it's surgically removed, then they're likely to just form another keloid because once you surgically remove something, you're creating a surgical incision and more scar tissue is going to form from that incision. So keloids are kind of difficult to deal with because to remove them, you have to create a new incision, which creates the potential for more scarring. So that creates its own set of problems. In large wounds, if the healing needs help to occur, suturing may be required. So suturing is just bringing the edges of the wound together to help it heal faster, prevent infection, and reduce the amount of scarring. So here you can see suturing on the left with sutures. Sutures are the name of the, string or thread being used. You can also use staples in very large wounds, like in abdomen. Sometimes they use it in heads. You can also use a liquid adhesive, something like Dermabond, which is basically like a liquid glue to seal the edges. Sometimes we use them in the ER. I was an ER nurse for a really long time. We'll use them for something like this near on heads or near eyes of kids. Please do not ever try this at home. But it is a lot easier for medical personnel to try to do this with a child instead of trying to get a needle near a kid's eye when we have to hold them down. It's much less traumatic. And if the cut is rather superficial, then trying to strap the child down and hold them and get a needle near their eye is much less traumatic for the child to glue the cut shut than to try and put a needle near their eye. So that's why we do that. But for the love of heaven, do not try to do that on your own. It has lots of potential serious side effects if you try to do that on your own. So this is my public service announcement. Do not try and do that on your own. Okay, so that is. Oh, there's a keynote from the publisher. Scab seals and protects a wound. Good to know. All right, so that covers the topic of burns and wounds. Like I said, it is a very brief overview. So that's my mini lesson for today. If you have any questions, of course, send me an email. I thank you for your attention, and I will be back with another lesson. And I think we only have one more for this chapter. Thank you.